At the outset, I would like to thanks to Foundation and Academy for inviting us for here for talk. And I'm going to speak about dengue outbreak in 2015, the AIMS experience. This study was done at Department of Medicine at AIMS New Delhi. And we have taken the data of the patient who has been admitted in the ward. And as we know that dengue is the major international public health concern. And as for global scenario, emergence and re-emergence in the newer areas and make more than 100 countries half the world population at the risk. And Indian scenario accounts about 20% of the total dengue population. So in 2015, we have seen the major outbreaks after many decades, and about 99,913 dengue patients have been diagnosed all over the country, and we had around 220 deaths nationwide. And in Delhi, we had 15,816 dengue cases, and out of those, we have 60 deaths, and the case fatality rate was 0.38%. And it was twice the national average. So what is importance of this study? The dengue epidemics are unpredictable in their frequency and severity. Wide knowledge gaps exist in the various aspects of dengue in pathogenesis, treatment, and prevention. And this, what was the study design? That it was a prospective observational study, and study was done at the Department of Medicine, AIMS New Delhi, and study period was August 2015 to November 2015, and ethical clearance was also obtained before starting the study. So what was the inclusion criteria? We have included the adults who have aged more than 15 years, and who has been microbiologically confirmed for the dengue, admitted under the Department of Medicine at AIMS New Delhi. And exclusion criteria was age less than 14 years and refusal to give written informed consent or patient managed to outpatient basis. So coming to study design, we have screened 510 patients who had acute febrile illness with thrombocytopenia suspected for dengue from August 2015 to mid-November 2015. And then further, we excluded 141 patients who had other diagnoses like malaria, viral encephalitis, viral hepatitis, non-specific viral illness, enteric fever, and leptospirosis. And then further, we have done the microbiologically confirmed patient. We have taken 369 patients who has given the written consent and who has been divided into 3 groups. One is dengue fever that had 198 patients, and there was the dengue hemorrhagic fever group that had 125 patients, and one was the dengue shock syndrome that was the most serious patient, was 46 patients. So what was the outcomes or objective of this study? To compare the clinical profile of dengue fever, dengue hemorrhagic fever, and dengue shock syndrome, to compare the laboratory parameters of dengue fever, dengue hemorrhagic fever, and dengue shock syndrome, to identify predictors of disease severity, and to identify predictors of mortality, and to identify the predominant serotype in 2015 in Delhi outbreak. So coming to results, we have enrolled 369 patients, I already mentioned earlier, and out of 369, we have 22 deaths, about 6%. And out of 22, 19 were dengue related, and 3 were unrelated to dengue. And you can see here we have about 48% patient who dies who had dengue shock syndrome. So maximum mortality was occurred in the patient who had dengue shock syndrome. And we have also seen the about 80% patient who has been referred from the other hospital, they have been died. So coming to demographic profile, and you can see here that we have 369 patients, and the duration of illness and at the presentation and comorbidities were the statistically significant in the group who suffered with the dengue shock syndrome. And what about the clinical features? So if you see the retroorbital pain and conjunctival congestion were the independent factor, and they were significantly difference in the all three groups. Other common features were rash, bleeding, abdominal pain, abdominal tenderness, vomiting, diarrhea, abdominal distension, and hepatosplenomegaly. What about other clinical features? We have dyspnea at rest, oliguria, and aldosterone. Those were common in the DSS group. You can see here they were significantly different in the DSS group as compared to dengue fever and dengue hemorrhagic fever. The other common clinical features were encephalitis, myocarditis, and many of patients in the DSS group required the assisted ventilation and dialysis also. So what about the laboratory parameters? So you can see here that hemoglobin, platelet counts like thrombocytopenia and leukopenia and leukocytosis were independent factor in the DSS group, which was the significant difference from the dengue fever and dengue hemorrhagic group. So coming to predictors of severity, we have duration of illness at presentation more than 5 days, conjunctival congestion, and dyspnea at rest. These were the independent predictors of severity in the dengue shock syndrome group. And predictors of mortality, the age more than 25 years, total leukocyte counts, and ARDS and encephalitis, they were the independent factor of mortality in the dengue shock syndrome group. We have also done the serotype analysis in 75 patients, and sample has been sent to the NIV Pune, and out of those, 17 patients had the positive serotype, and 13 had DEN2 serotype, and 4 patients had DEN4 serotype. So what is the take-home message? Atypical manifestations are common. Platelet counts does not correlate with bleeding rash outcomes, and prophylactic platelet transfusion is not recommended. Use of validated predictors of severity and the mortality is necessary. Timely referral access to the medical care is important, and DEN2 and DEN4 are the identified as the predominant circulating serotypes in India. I would like to acknowledge Professor Sharma and Dr. Siddharth for this study.
Thank you, Professor Sinha. Y a-t-il des questions à poser sur cette étude?
Can I continue?
No, no question. So you, yeah. Prenez le micro. Le micro, appuyez sur le petit bouton rouge. Voilà.
I am Dominique Salmon from Paris. We met yesterday.
Yeah.
And in your experience, is there any predictive factor, but not during the illness, but before the illness, that are predictive of severe dengue? for example, diabetes or renal insufficiency, or some factors that we could focus on to choose who could be vaccinated or not?
Yeah, sure. I have shown in the data we have certain comorbidities like kidney disease, liver, and cardiac disease, and heart disease. They are the risk factor for the independent risk factor for the heart disease. So you are correct. We can focus on this group and we can give the vaccine in this group, and we can see the result in the follow-up.
Actually, the age also is a risk factor.
Age was also
So a very young child, an elderly person with comorbidities, they haven't done as well as young patients with dengue serotypes. And also, your question is very important, that even younger patients have died. And they have gone into very rapidly into dengue shock syndrome. So that your question is, can that be predicted? So that is something, the area for concentration in these patients, then what can predict the severity of dengue? So even without comorbidities. In some patients, very healthy young adults have died very rapidly, disease progresses in them, and with no comorbidities. So that is, and they do give some lead time, but the question is that can that lead time be used to limit the progress? That we don't know. Because I distinctly remember one young adult who kept coming at least 3 times to our emergency department, and he was found very stable. And then finally, when the 3rd time he came, he very rapidly deteriorated. So that is something which we have not discovered what's the reason for that. The other thing that platelet count does not correlate with the bleeding or the requirement for platelet. So some patients with very low platelet count will not bleed, but some patients even with normal platelet count start bleeding. So that is another observation which is there, which needs some detailed look on the data.
Do you think any genetic factors could be involved?
That's an area for the whole wide and open, because this is only, we saw this upsurge in last 2 years, 14 and 15. 16 dengue was not that much. So 14, 15 was real bad years for dengue in Delhi at least. So I think that's the area for more work, more concentration in those cases, and I think very careful cohort maintenance would help in that, but what we are going to discuss.
Merci beaucoup. Nous passons à la deuxième communication.
Thank you very much. Now we're going to go on to the second presentation by Professor Sinha on a dengue vaccine in an Indian cohort. You have the floor.
I'll just find it. Yeah. So coming to next talk, that is a cohort collaboration in dengue vaccine and Indian perspective. And as you know that dengue is caused by dengue virus, and this is a single-stranded RNA virus, and it have 4 serotypes: dengue 1, dengue den 1, den 2, den 3, and den 4. That is caused by mosquito. Vector mosquito is Aedes aegypti and Aedes albopictus. So what is the dengue infection immune response? Following a primary infection with the 1 serotype, protection against the infecting serotype, mainly homotypic protection is considered long-lasting. Temporary cross-protection is induced to the other serotype, like heterotypic protection that lasting about 2 years on average. So what is CYD tetravalent dengue vaccine? It is a chimeric yellow fever tetravalent dengue vaccine, and CYD TDV has been evaluated in 2 pilot trials in phase 3 randomized clinical trials known as CYD14 and CYD15. The schedule of the vaccine is 0, 6, and 12 months, and the route of the vaccine is subcutaneous. So this is the study which has been published in the Lancet and NEJM in year 2014 and 15. And you can see here the study design of CYD14 and 15 was phase 3 randomized controlled trial. And it was published in the Lancet in July 2014. And other study was published in NEJM in January 2015. The site of study were in Asia Pacific in 5 countries and in Latin America in 5 countries. So in Asia we had Thailand, Indonesia, Vietnam, and 2 more countries. And Latin America, there was Mexico and Brazil. They were the major centers in Latin America. So if you can see here what was the results of CYD14 and CYD15 study. In CYD14 study which was done in Asia, there was a 56.5% reduction in the symptomatic dengue fever, and there was 80% reduction in the severe disease, and there was about 67% reduction in the hospitalized cases. And results of CYD15 study was about 61% reduction in the symptomatic dengue fever, 95% reduction in the severe disease, and 80% reduction in the hospitalized cases. So you can see here that this vaccine is very effective, and in both the trials they have shown the good results. So what is WHO position? The countries should consider introduction of the dengue vaccine only in the geographic setting where epidemiological data indicate a high burden of disease. The seroprevalence should be approximately 70% or greater in the age group targeted for the vaccine in order to maximize public health impact and the cost effectiveness. The vaccination of population with the seroprevalence between 50 and 70% is acceptable, but impact of the vaccination program may be lower. So what are the challenges with the introduction of dengue vaccine in India? So India has widespread prevalence of dengue 2 virus, and this vaccine is not very effective against dengue 2 virus, and there is a reduced documented efficacy of vaccine against dengue 2 virus and lack of trials in the Indian population. So there is a need for a dengue vaccine cohort in India, and identification of a dengue vaccine cohort is the need of the hour in the path of the introduction approval of the dengue vaccine in India. That we are going to discuss in the afternoon meeting, what is the status at present in India. So what is the trial design? It will be a randomized, observer blinded, placebo-controlled, multi-center phase 3 trial. And the patient subjects will be divided into 2 groups, will be randomized into 2:1 ratio. There will be dengue vaccine group. In that group, we will give the CYD dengue vaccine at the 0, 6, and 12 months. And other will be the control group where we will give the 0.9% NaCl at the 0, 6, 12 months. And the site of study will be AIIMS, New Delhi, and other centers to be decided in the other part of the country. The trial design and methodology. The detection of dengue cases in 2 phases. One will be the active phase, another will be the hospital phase. In active phase, the surveillance to maximize the detection of symptomatic confirmed dengue in order to assess the efficacy. And it will begin from the dose 1 and will be continued till 13 months after the dose 3. The initial minimum frequency of at least 1 contact every week, and the purpose to provide a reminder to go to the trial center or healthcare center in the event of the febrile illness. In the hospital phase, this phase will begin after active phase, the dengue screening in febrile subject who require hospitalization, and it will continue for the 6 years after the dose 1, and minimum frequency of the minimum frequency of at least one contact every 6 months will be done. So what is reactogenicity and immunogenicity subset? So we'll have one subset of reactogenicity and immunogenicity, and in this, subjects from the East Center will be evaluated for the reactogenicity and immunogenicity to enable the generation of the center-specific data on reactogenicity and immunogenicity and baseline dengue antibody levels. The immunogenicity and reactogenicity subset will include a total of 2,000 subjects, 1,333 in dengue vaccine group and 667 in control group. So what will be the visit and contacts? So all subjects will have to come at least 7 scheduled visits, and the subjects from immunogenicity and reactogenicity subset will have to come for 2 additional visits, and there will be regular contacts by the phone calls, SMS, home visits, and the school-based surveillance in all the subjects. So what is the primary objective? To assess the efficacy of CYD vaccine after 3 vaccinations at the 0, 6, and 12 months in preventing symptomatic confirmed dengue cases due to any of the serotype. The primary endpoint will be symptomatic virologically confirmed dengue cases occurring more than 28 days after dose 3 during the active phase, and it will be defined as the acute febrile illness, temperature more than 38 degrees centigrade on at least 2 consecutive days, and number 2, virologically confirmed by RT-PCR or dengue NS1 ELISA antigen test. So what will we do? We'll just enroll 10,000 patients from different centers in India, and we'll divide them in 2 groups. And the vaccine group will have 6,666 patient subjects, and in control group will have 3,334 who will receive the placebo at the 0, 6, and 12 months. And then we will follow up them for 13 months after the 3rd dose. Total follow-up will be about 25 months after the 1st dose. And we'll see the annual incidence rate in both the groups, and we'll assess the efficacy of the vaccine. What will be the secondary objective? To describe the efficacy of CYD dengue vaccine in preventing symptomatic virologically confirmed dengue cases after the 3rd dose to the end of the active phase. And then number 2, to describe the efficacy of CYD vaccine in preventing symptomatic virologically confirmed dengue cases after at least 1 dose. Number 3, to describe the efficacy of CYD vaccine in preventing symptomatic virologically confirmed dengue cases after 2 doses. And we'll assess the safety also, and we'll describe the occurrence of severe adverse events, including serious adverse events to special interest in all subjects throughout the trial period. We'll also see the immunogenicity in subset, and we'll describe the antibody response to each dengue serotype after dose 2, after dose 3, and 1, 2, 3, 4, and 5 years after dose 3. And we'll see the reactogenicity to describe the CYD dengue vaccine after each dose. So what will be the sample size? Due to lack of cohort studies in India, annual incidence rate of dengue infection is not known. In cohort studies done in Thailand, Philippines, Vietnam, and Indonesia, the annual incidence rate was found about 1.3%. So on basis of that, we'll make a sample size of 10,000 patients, and we'll divide in the 2 groups. And coming to inclusion criteria, we'll have inclusion criteria of age between 9 to 45 years. All subjects have to be in good health based on the medical history, physical examination, and assent form or informed consent form has been to be signed by all subjects. An ethical approval have to be taken for the study. And other inclusion criteria are subject able to attend all scheduled visits and to comply with all trial procedures. For a female of childbearing potential, use of an effective method of contraception or abstinence for at least 4 weeks prior to first vaccination until at least 4 weeks after the last vaccination. So what are the exclusion criteria? Self-reported pregnancy, currently on breastfeeding, self-reported or suspected congenital or acquired immunodeficiency, long-term corticosteroid therapy in last 3 months, chronic illness that in the opinion of the investigator, and anti-cancer chemotherapy, and receiving of the blood or blood-derived products in last 3 months, and current alcohol abuse or drug addiction, and planned receipt of any vaccination in last 4 weeks. So this will be the, you can see here, we'll give the first vaccine at the 0 month, then we'll give at the 6 months, and then third vaccine will be given at the 12 months, and then there will be a long-term follow-up from year 2 to year 6, and we'll assess the efficacy of vaccine in this duration, and we'll also assess the side effects as we planned. So this is just a planned trial calendar that we chart out, and this is we'll start the study in June 2017, and this will end at March 2023, and the planned inclusion period will be June 2017 to Feb 2018, and then first vaccination will be given between June 2017 to Feb 2018, and the planned second vaccination between December 2017 and August 2018, and then third vaccination will be between June 2018 to Feb 2019, and planned interim clinical trial report will be done at July 2020, and the planned end of the trial will be March 2023. Okay, thank you.
Thank you, Professor Sinha. Some question. One question. I am not used to those kind of trials. For vaccine I worked, you have a short time to work. That seems very long. Are you sure to keep all your patients during 6 years to follow them?
Yeah. As I mentioned, we'll do the close follow-up in all the patients.
Yes.
And we'll contact through SMS, phone calls, and we'll do the personal contacts.
Thank you. Thank you. Dominique?
Thank you very much, Dr. Sinha. I have a question concerning the timing with the registration of the vaccine. Do you plan to do first the trial and then discuss the registration of the vaccine in India, or to register, for example, the vaccine for a certain category of people and do the trial at the same time?
I think this is a government decision. We have to discuss about that in the afternoon.
I'm sure that we need to register for trial also. No, for trial also, because we'll need ethical clearance, and for that DCGI permission needs to be there. So I'm sure that they would ask for registration for trial also. Yes, more together, yes. So that needs to be expedited.
Patrice Debré.
It's a question related to immunity. Immunity is due to neutralizing antibodies, or are they working by ADCC? You know how the antibodies are working to fight the virus?
Is there anything in the protocol that you would assess the
Yeah, we'll assess the antibody.
antibody titer?
We'll assess the immunogenicity, and in our study, we'll do the antibody assessment.
How easy or difficult it would be?
I think that Dr. Dhar can help it.
He is going to talk about that.
Yeah.
Thank you very much. One more question? Yes.
Just pointing out, I noticed that
No, I mentioned there was 2 studies done, CYD 14 and CYD 15, and they have done a study for, I mean, they have given this vaccine 0612, and after that they have followed up for 1 year. But as per recent guidelines, we have to follow up them for at least 5 years after the last dose of the vaccine. So we are trying to follow for the 5 years after last vaccine.
I think pending approval of registration and starting, why not get the antibody titer tested in those who have already had dengue documented?
Yes.
Call them back and have the titer, because how soon they develop this titer, and it's said to be the lifelong immunity against dengue, although rarely one can still have with a different den. One can have again dengue, but it's very unlikely, and that is one of the reasons this year why dengue did not surface in the same proportion as was in 14 and 15, that people in that geographic region had some immunity against dengue when they were exposed in earlier 2 years, what we call herd immunity or whatever.
So in the like in same serotype, they understand that this immunity is long lasting. But for cross,
so that's what I'm saying.
Yeah.
You can recall some of the patients,
Right.
at least whatever number you can get, and see the titer in those patients.
Right, sir. We will do.
Thank you very much.